Message me if I am audible. If you are able to hear to me, please respond. Say hello to me, the chat box, so I can see your comments as well. So we are going to discuss the INI-CET May 2023 questions for ENT that were asked in the exam. So I hope everyone's paper went well. ENT questions were particularly very interesting. Okay, so we'll discuss these questions one by one. I hope I'm audible to everyone. Right, okay, let's start with the first question over here. Okay, so the first question, and this is a repeat question. Arrange the sequence of auditory pathway from peripheral to central. And this question is a repeat question. It has been asked multiple times. And the best thing about this question was, in this exam, this question got repeated twice. So one question, double the number of marks. Wow. Okay. So, and we have been discussing the mnemonic over here multiple times. E. coli ma. Okay, the auditory pathway. So you see over here E. coli ma. So inferior colliculus you can place over here. I have been telling you this. Okay, cochlear nucleus you can place over here. That was B. And then auditory cortex was C over here that you can place, and medial geniculate body was D. So that was the answer B, A, D, C. And this question, so question number 1 into 2 times. This question came twice, so there was some technical glitch over there. I heard 2 or 3 questions in fact had the answer. In some of the systems, the answer was showing. That was another technical that I saw. Some students, they told me. Right. Okay. And this question has been repeated. I think this is a favorite topic of AIMS examiners, INI-CET examiners. It was asked in the AIMS May 2019 and the INI-CET June 22. Twice this question has been asked in your exams. It was asked once again today. Right. So the answer over here was B, A, D, C. So arrange in the sequence order. Let's go to the next question. Very interesting question, and I know this question is going to have multiple controversial answer by different faculties, because the language over here is little bit tricky over here. So I'm again saying this question is going to get, you will get different answer from different faculties, and that's because the question is not complete, or question is not that clear to everyone. Why? Let's look over here, and I'll share my thoughts on this question with you. A 14-year-old girl is unable to understand words, but has normal speech and language. Okay, so that means she is not able to hear, she is not able to understand the words, but has normal speech and language. So that automatically tells you that this girl is having post-lingual deafness. We understand there are 2 types of deafness, prelingual deafness and postlingual deafness. Okay, so this girl is having postlingual deafness. There is no congenital anomaly in this patient. Okay, right? Something that has happened post deafness. Her Peotone audiometry and ABR shows inconsistent results. Cortical responses were absent. So this is very important. What is the most likely diagnosis? Now let's look at the choices. Cochlear autosclerosis, malingering, Michel's aplasia, and auditory neuropathy. Michel's aplasia is absence of cochlea. So that's a congenital anomaly. Right? If that is there, she will not develop any kind of language. Right? So Michel's aplasia is definitely out over here. Right? Now, this girl is having problem in ABR. The ABR results are inconsistent. Now, if the malingering patient is saying false things. So when the patient is saying false things, now in that case, the Peotone audiometry may be inconsistent, because that is subjective test, but ABR is an objective test that will show particular waves, the wave pattern as we know, right? So wave 1, 2, 3, 4, 5, 6, 7, they will be visible in the ABR, but over here the ABR is also inconsistent. So malingering is also out. Right? Now there are 2 confusion left. What is cochlear autosclerosis, or is audiometry? Now cochlear autosclerosis, it generally has conductive hearing loss. Sometimes it can also have sensorineural hearing loss, and this sensorineural hearing loss is a cochlear type of hearing. Right? Now, when that is there, now you see the cortical responses were absent. That is something you will not find. Okay, so it has nothing to do with the cortical responses. And the ABR, yes, when the cochlear deafness is there, the waves will be absent. Okay, but it will not, the result will not be that it has inconsistent results. So something like that is seen in one condition, which is known as auditory neuropathy, right? Auditory neuropathy can be both congenital as well as acquired. The right answer to this question is auditory neuropathy. I was having a discussion and some people were saying, no, it should be cochlear otosclerosis. But in cochlear otosclerosis, what I believe is that the cortical responses will not be absent, number one. And number two, auditory neuropathy can be both congenital as well as acquired. So the answer to this question is, in my opinion, auditory neuropathy. Right? So that was a very interesting question. Then we had another repeat question. This question was there. It's a overlapping question between and ophthalmology. We use this block. It was a question on the block of the face. We use this block consistently for our rhinoplasty surgeries, right? So, and the nerve supply is coming to the orbit. So it's a overlapping question between ENT and ophthalmology. So choose procedure done in the following given image, right? And this is a very tricky question. You know why? Many times we have this tendency to mark the answer over here as anterior ethmoidal block. So what we have to do is look very carefully. Now, if in your exact question, this is the medial canthus, if the block is given above the medial canthus, then your answer is, I've discussed this in my answers also. Okay, so yes, hello dear, I can see your chat. So if the block is below the medial canthus, then the answer is anterior ethmoidal block. Okay, so just remember, if it is below the medial canthus, it is anterior ethmoidal block, right? And if it is above the medial canthus, then it is nasociliary block. So as you can see over here in this photograph, it is right above the medial canthus. So answer over here definitely will be the nasociliary block, right? Okay, so that was the answer in this question. Pretty straightforward question. It is again a repeat question. It was asked in the INI-CET July 2021 question, and I have discussed this question earlier as well, right? Okay, now another interesting question. This was a clinical question given over here. This time, a South Indian female farm worker by occupation. You see, some typical history findings were given over here. Specifically mentioned South Indian female farm worker by occupation with history of contact with cattle, presented as shown below in. So what do you see over here? You can see over here in this photograph, there is a polypoidal mass. Okay, polypoidal mass. And as you can see over here, this is a mulberry shaped mass, right? So even if you are not able to identify as a mulberry shaped mass, all you can see that this is a polypoidal mass. And then a histopathology image is given. What can you detect from all this, from the history, from this clinical photograph, from the histopathology? So what can you see over here? So see one by one: female, Indian female, South Indian female, farm worker, history of contact with cattle. What disease do you remember? Let's look at the choices. So I have only 3 choices till now. I'm still missing the 4th option over here, right? So please, you can just tell me yes. Yes, dear Dr. XYZ, the answer you are saying is rhinosporidiosis. Yes, I agree to your answer over here. Yes, but let's look at the options. Let's look at why we have come to this question, why we have come to this answer. You see, rhinosporidiosis, we all know rhinosporidiosis is common in southern coastal India. Southern coastal India. So that is one thing which is pointing. You see, so South Indian female, one thing. And this disease, it is found in cattle dung. Okay, human beings are accidental hosts. So cattle, South India, 2 things, two hints which are taking you directly towards your answer of rhinosporidiosis. But sometimes the examiner may give you something which is tricky. You see, you can see over here, this is in the nose, there's a polypoidal mass. We describe it like a strawberry, like a mass, right? Okay, not a mulberry, but a strawberry like a mass. Many students were saying today to me that it is mulberry. So that's why I've written the word over here, mulberry. But the actual word that we should use is a strawberry like mass, because it sometimes bleeds when you touch it. and there is white yellow spots over there. Now histopathology, it this is what the histopathology actually look like. It look like that there are fungal septate spores over here, sporidium kind of structure is seen. So that is why it was initially confused fungus, right? So the answer over here is rhinosporidium. Yes, yes, I agree with all of you. What you are saying in the chat, it is rhinosporidium. You have marked it. Correct. Very good. All right. Let's go to the next question over here. Now, very simple, straightforward question was given to you. Identify the given. Okay. So 6 question came in the exam, and this is the 6th question actually. The first question came twice. So that was a easy, straightforward repeat question. And this question is again a straightforward repeat question. We can see over here that there is a mucus cyst which is arising from the floor of the mouth. It is bulging in the floor of the mouth. So what do you see? The answer over here is, okay, it is ranula. Yes. So that was the answer. So these questions, they came in today's exam, and these are all straightforward questions. Number one. So you see, ENT was pretty easy. I'll say that straightforward repeat questions were there. All right. Only 2 or 3 questions which were 2 questions were there which were new question, but again they were from the previous year topics. They have been asked multiple time in the exam, and they were straightforward clinical questions. So it was a pretty easy, straightforward question from ENT aspect. So I wish you all best of luck, and remember the remaining subjects are being discussed in the LN Next app. So I'll request everyone to download, install the LN Next app, and you can watch the discussion of all the subject in the app, and even this discussion will also be available in the app for all of you to watch for free, right? So see you all. We are coming up with some more sessions in Delhi, both online as well as offline in Delhi, Hyderabad, Bangalore, Chennai. So we're coming up with different sessions, both online as well as offline. We'll also coming up with some counseling sessions for you, for people who have cleared the exam or who are going to clear the INI-CET and pick up a seat over here. So see, you have some confusion, we'll be coming up with those sessions for you. So we'll see you all, meet you all very soon. Best of luck for your studies.
Hi, good evening, ladies and gentlemen. We are now going to start the INIcet Recall May 2023 ophthalmology. Sorry for the slight delay. But remember, at the outset, as I say always, we've had a tough exam. After many students staggering out of the exam after skull busting, are scarcely able to remember their own name, forget about them. So, this is the first cut. First cut, questions that we've got. Remember, we've got the impressions. Impressions could be somewhat off target. Come back to it again. This is the first rough cut that I've got. I've got around 5 questions, and let's do that one by one. And since we are live, those of you who want to ask me some questions, we always on. Please, let's start that. Okay. We have this 2023 May INIcet, and the first question is: what of the following? Which of the following a direct gonioscope? Okay. We have choices: 1 Goldman, 2 Richardson, 3 Zeiss, and 4 Copies. Now, first of all, gonioscopes are instruments designed to check the angle, the angle of the word gonio means. And why we can need a gonioscope is because we cannot see the angle directly because of the critical angle. So the light rays, because of total internal reflection, they go back, they reflect inside. From the, why you cannot see the structure of the angle, that they reflect back into the eye. The critical angle has to be have more than 46 degrees. Only then they can escape. That is why I require gonioscope. And remember, we have two different types of gonioscope. We have direct and indirect. Direct, as the word says, you can see directly. So you just go directly on the eye, put the lens onto the eye. Directly here, the patient is lying down. He's fine, and you have a direct view of the angle. That's called direct gonioscope. But much more popular are the indirect gonioscope. Here, we see the angle reflected. That's why it's total internal reflection policy. So reflected, and this is much more easy for the patient because he's sitting in a clinic with the slit lamp and the indirect lens against his eye. We need a coupling media, and we can see indirectly the angles. Direct gonioscopes are not that popular as indirect. However, since the question is a direct gonioscope, so we have to answer. The direct gonioscopes here are the Richardson and the Copies. So we have this choice 2 and 4, choice C, correct. Indirect, the ones we that use are the Zeiss lenses and the Goldman. Because the Zeiss and the other Goldman are indirect lenses, means that we put them against the eye with the coupling media and see them through the slit lamp, and the angle is reflected indirectly. They're more popular, but the question is direct. The answer is 2 and 4, the Richardson and the Copies. Very well. Next question for us is identify the structure marked here, and here we have a big problem because this is a structure which is very small spaces around the lens and the vitreous. We have the lens capsule, canal of Hanover, Eagle's line, and canal of Petit. And the arrow that have been given to us seems to point towards base, which lies between the anterior hyaloid fossa, anterior hyaloid face rather, and the posterior zonules. So the answer here seems to be the canal of Petit. Now we will just discuss a little bit more. What does that mean? Okay. Remember the question that I have been given, or we have been given, the arrow points to a very small space between the post-equatorial zonules and the anterior hyaloid face. Okay. So that is the canal of Petit. And for that, for more clarity, let us draw the diagram and see details. So suppose that we have the cornea here. Again, we need to be careful about this because the cornea, the outermost layer of the eye, and iris, draw this uvea, red iris, ciliary body, choroid, and then blue one. Usually do the retina. Very well. So you've got the 3 layers. In 5 strokes, we draw the eye, and then we this. This is the these are the zonules. Remember these anterior zonules. Please remember this is called the equator. Okay, the lens. We have a lens like this. A lens. Remember the superior and the inferior poles we call the equator. So we have zonules in front of. Remember of the equator we call it anterior zonules, and we have zonules behind the equator called posterior zonules. So this is the zonules, and this is the iris, this is the body. And remember the vitreous is sloshing about here. Vitreous is sloshing about all here behind the lens. Huge space. The vitreous is sloshing around, and this is a small space between the vitreous and the lens. Now, what the fine points of these spaces are that between the anterior and the posterior zonules, anterior equatorial and posterior equatorial zonules, this little space between the zonules that is placed anterior to the equator and zonules as posterior is the space which we call as the canal of Hanover. Okay, canal of Hanover. The canal of Hanover runs between. So that is how I used to memorize Han and runs. Okay, Han and runs. Canal of Hanover runs between the small space between the anterior and the posterior zonules. Okay, so that's one. Now, this is therefore, but there's another space between the anterior hyaloid fossa or face rather and the posterior zonules. This little space, and that question pointed to that, and this is the canal of Petit. teeth, P-E-T-I-T. Petite means small in French, and because there's very small space, very little space between the zonules and the antihyaloid phase, this is the canal. The question seems to point at that, and that is the canal of Petite. Okay, then we have another choice, as the question says, you know what the lens capsule is. What is Egger's line? The Egger's line, this one, remember where this is the vitreous and this is the posterior capsule. So when there is a Weger's ligament here, and the Egger's line is a small oval line where the Weger's ligament attaches on the posterior. The small space, this small circular line, which is the space for the posterior capsule and the Weger's ligament to join together. This is called the Egger's line. Often vitreous hemorrhage starts there. Vitreous hemorrhage, remember, this is part of vitreous, starts there. That's the importance of the Egger's line. But the question where the arrow seems to point here seems to point to the canal of Petite. Okay, so the answer is here, canal of Petite. Not easy, mind you, not easy at all. Question number 3, this is the first of the clinical questions. Which of the following is true regarding perimetry? Perimetry, remember, visual fields, and the earliest and the most specific features of glaucoma are constriction of the isopters and bearing of the blind spot. Is this true or not? It is incorrect. Remember, neither are the early nor the most specific features of glaucoma. Constriction of isopters, bearing of blind spots are actually very non-specific. They are field different, but they can be seen in other conditions also. So they are not the specific features of glaucoma, and neither are the earliest. Choice B, kinetic perimetry is best for monitoring visual field changes in a patient diagnosed with glaucoma. Incorrect. Again, please remember kinetic, but remember the basic difference between static and kinetic perimetry. Types of perimetry. Perimetry, visual field. Remember, visual field basically checks the optic nerve function. I'll ask you a question, what is the single best method of examination for assessing the function of the optic nerve? And the answer is perimetry. So the difference between visual field and vision is very intricate. Remember, vision is straight ahead, that is testing the function of fovea and the macula. Visual field is an area of space that is testing the optic nerve. And remember, visual field is not the same, though it is allied to the vision, but it is perfectly possible for you to have a very poor visual field and yet you have very good vision. They are not the same at all. They sound similar, vision and visual field. And remember, vision tests your fovea and macula, visual tests the function of the optic nerve. So in visual field perimetry, static and kinetic. Now look at the word. Static means that we test the field. There is a spot here, does not move because it's static, so it does not move. So what we do, we ask the patient, can you see that spot? Okay. Now, this spot is a standard size. It's size 3 of Goldman. And the illumination we can reduce, we can increase. But it will not move, and this glows only for a brief second, say around 0.2 seconds. Humphreys at least, only 0.2 seconds. You are exposed to this light only for 0.2 seconds. And if the patient can see it, he clicks on the remote. If he can't see it, doesn't click. So then we can increase or decrease the intensity of the light stimulus. This is called static perimetry. Why? Because the point of light is moving. In kinetic perimetry, however, the stimulus is moving. So we typically take a stimulus from the periphery, non-seeing area, and give it. So we first, in kinetic perimetry, this sort of stimulus, it moves from a non-seeing area to a seeing. At a certain point, as the patient starts seeing it, fix that. The basic difference between static and kinetic movement, right? Now, please remember, for glaucoma, static perimetry is considered gold standard. For neuroophthalmic field defects, we prefer kinetic perimetry done by Goldman, not done by Humphreys or Octopus. They are the two standard forms of perimetry, static perimetry, either Goldman, the big one, Octopus, or it can be Humphreys. Humphreys is usually more common. And for kinetic perimetry, Goldman. So to summarize what I was saying, that perimetry can divide into two types: static, where the stimulus does not move, and kinetic, where the stimulus does. Please remember, static is more useful for glaucomatous field defects, and kinetic is more used for neuroophthalmic field defects. This preferably optic neuritis, AION, papilledema, so on and so forth. So therefore, this is incorrect also. This A is incorrect, B is incorrect. Now, visual field defects are classified as glaucomatous only if they're associated with relevant optic nerve head changes or optic disease. Absolutely correct, right? This is correct. The visual field defects are classified as right. That's if they correspond to the optic disc nerve. So they should be corresponding. It cannot be that the optic disc is showing some other change and the visual field is saying something else. Okay, so this is correct. So please remember this answer C is correct, and D we didn't have a choice, but this is a statement about static perimetry. So would probably definition of static would say that static perimetry is a stimulus in which the stimulus does not move. We only increase the intensity short bursts, and this is the definition of static perimetry. So if we take that statement as correct choice, then C and D would be correct answer. However, since I do not know what the D choice is, in the absence of the D choice, I would say C. This is a good question because it is static and kinetic perimetry. Very well. The next question is the image indicates findings after administration of phenylephrine eye drops. So we have two images of which we have been only able to get one here, and which shows this nodule on the episclera or the sclera as the case may be. And the question says the image indicates the finding after administration of phenylephrine eye drops. So remember, when we have between episcleritis and scleritis, because they are layers very close to each other, the one gold standard is to do the phenylephrine blanching test. Put a drop of phenylephrine, could be 5%, 10%, and phenylephrine blanches the blood vessel. So if it is episcleritis, the redness would disappear immediately, it will become white. But if it's scleritis, because sclera is deeper behind, so the phenylephrine is not able to blanch or constrict the scleral blood vessels, so the scleral redness would remain as it is. Okay? So remember, in this case, you can clearly see the redness is still there. It is still there. Then, so if it is still there, so that means the answer is going to be nodular scleritis. It's not a teen cyst. Episcleritis it would have been, because the answer would have been episcleritis if it had become white. If it had become white and was completely blanched, because superficial, it blanches easily with phenylephrine. Nodular flicton is not the answer. Flicton is an antigen-antibody reaction, and the classic sign of flicton is pain. And on examination, you do a fluorescein stain, you would have find there were ulcer at the top of the flicton, and that would have. So the sign of flicton is that on staining with fluorescein stain, it picks up the stain because small ulcer at the top of the flicton. The answer, ladies and gentlemen, here is nodular scleritis, because it is completely red, blanch at all. Very well. That wasn't a very difficult question. I hope you got, most of you have got it correctly. And then this is a little tricky question in the sense that there is not enough information here. It says, what is the sequence of staining for a dry eye evaluation? Now, what does that mean? Sequence of staining for eye evaluation. You know that in keratoconjunctival sicca, there are multiple tests. You know the multiple tests. One of the most useful ones are, of course, the staining test. Now, what I think, what according to me, is that sequence of staining would mean that dry eyes typically progress first from the conjunctival dryness and then from to the corneal dryness. So usually the first conjunctiva becomes dry and then the cornea becomes dry. As if you remember the vitamin A deficiency xerophthalmic classification of WHO, the modified WHO classification, where you know that X1 stands for the XN, sorry, let's start with the first XN, that's nyctalopia earliest. X1 stands for conjunctival dryness and X2 stands for corneal xerophthalmia. So in that sequence, if we look at that sequence, that is the ideal sequence. First the dryness hits conjunctiva and then the cornea. Then the conjunctival dryness, remember, in that case, the conjunctival dryness, X1 is conjunctival dryness, X2 is corneal. Get confused by my terrible handwriting. Conjunctival dryness X1. So in X1, remember, the stain of choice is lissamine green. Okay, lissamine green is a stain which you just touch the conjunctiva with the stain and pick up the stain immediately. Green color stain very easily. This is very useful. You can also use a rose bengal, but rose bengal is not used much nowadays. Very irritating, and the patient gets hurt when you put up. Highly irritating, and the patient may have a foreign body sensation, pain when you use rose bengal. However, both rose bengal and lissamine green, they test for conjunctival dryness. So we can, I would suggest that we start with this. This is number one. In the absence of lissamine green, which is not usually available sometimes, rose bengal is number two. and these would test, both of them are test conjunctival dryness. And then we go to the next stage of ACS or dryness, which is the corneal dryness. And the corneal dryness is the best way to look for corneal dryness is our fluorescein stain. Fluorescein stain. So in this case, if we go sequentially, and that is the correct sequence, they're asking the sequence of staining, is that we start with glycine, go to rose bengal. However, both of them can stain the conjunctiva. Remember, it's just that it's more comfortable for with glycine green. But fluorescein stain is a stain for the corneal dryness. These two are stains for the conjunctiva. So if we take it this order, if we take the interpret the question this, so I would say the answer would be D, which 3 is 1, 2 is next, and the first is last, because corneal staining means now you have very severe dry eyes with loss of vision. So with that, ladies and gentlemen, we have finished this little sequence. This of I don't want to take time of yours. This is a rough cut. And if you have any questions, kindly ask me, and we can discuss this later. So I hope that you all done well. I hope you've all done well, but if not, but just have to plug on. Remember, this is medicine, practice. Thank you very much, and all the best.